Arun Mohanty. So invite him to deliver his talk, and he'll be talking on OCT, insight into ACS pathology, learned from my experience.
So, thank you, Dr. Khanna and Asia Pacific Vascular Society for giving me an opportunity. This is the algorithm which is very famous for the ACS pathology, and all of us, we have understood. We have three kind of plaque morphologies in ACS particularly. Basically, we have a plaque rupture, most commonly seen calcified plaque, very rare, but they are troublesome. Plaque erosion, very common in Indian setting, particularly in young smokers. So there is thrombus with erosion. When you have calcified plaque, you get eruptive calcific nodule, which is the most dangerous anatomic finding. If it is unstable, very difficult to manage also sometimes, and it's a challenge for treatment in acute coronary syndrome. And most oftenly, all calcified lesions are superficial calcific plate or sheets. They are easily manageable, so it's not a problem. And calcified nodular protrusion, again a trouble, something, because in acute MI with a thrombus load, you try to avoid a rotablation or something. And many a time you misunderstand and misinterpret these lesions with thrombus, red thrombus or something, and you go with a balloon and put a stent, and your stent will land into under expansion. So this is the data. One can see they've taken 710 patients in a registry data for a OCT analysis. You can see this difficulty in ACS is poor image quality in majority. Large number of thrombus. In our practical experience, we have lot of thrombus. You cannot interpret the lesion behind, and sometimes you fail to have a very good flow in the coronary. So for acquiring a OCT image, you need a good flow in the coronary. Sometimes the flow is so sluggish, you get only blood artifact. So imaging is not that easy in ACS setup. You see 17 patients were taken for OCT evaluation, and plaque rupture group were 79, OCT erosion group 62, and many patients were excluded because of the poor quality imaging, and thrombus is a major problem. This is the erosion study, which is the most quoted study by XIII. One can see 1241 patients with ACS, plaque rupture being the most common. 50% of the patients will have plaque rupture, plaque erosion 38.4%. But this Western data is not Indian patients. Indian patients receive many more plaque erosion patients, particularly in young subset. And calcific plaque, calcified nodule or calcific plaque are very minimal, and superficial calcific sheets are being the most common variety, which is easy to manage. The trouble is again nodule or protrusion. This is my first case, 31-year male, 1 hour chest pain, evolved intervals, and ST elevation MI. The time he came to our casualty, the ECG has settled, and he was pain-free with a DT inversion, evolving interval MI. LVEF was 40%, 52%, managed with LMWH and DAPT for 1 day. Next day morning, he was taken off for an angiogram. We can see there is a filling defect in the proximal LED. And the OCT run was done. I'll skip the run. I'll go to the frames because of the time constraint. And one can see there is a large number of thrombus load, red thrombus, and the proximal vessel is very normal. And you can see there is a mixture of thrombus here with a wavy margin, irregular margin, suggestive of a plaque erosion. This is the most common variety in a young patients. They will come with this kind of acute MI. After 2 months of follow-up, one can see the vessel is very well seen and very well smooth flowing and TIMI3 flow. The OCT run was done, and one can see these are all very clear now. The thrombus, which was there in the previous index procedure, has gone. One can see the erosion, which was there, is totally smooth, and this patient was medically managed, and that is what we learned from erosion trial. Now, this is a 62-year male diabetic hypertensive post-pacemaker CHP outside Delhi. He got some chest pain 15 days back. The troponin was grossly elevated because of the pacing. The ECG was inconclusive. There was infraval hypokinesia with LVEF of 48%. One can see there is a hazy-looking lesion here. So we did an OCT for this patient. One can see there is a plaque rupture with thrombus within the rupture. There is a thrombus, layered thrombus. So it's a large vessel, proximal RCA plaque rupture that I did this case 2 years back. So at that time, we were very much sure if there is a plaque rupture of this kind has to be stented. So I put a stent, but this topic is also getting into controversy. If you have a 15 days old stable patient with a good lumen with a plaque rupture, you can leave it on medical follow-up also, but we don't have a systematic data. There are some data coming up to support that you can leave them without stenting if you have a TIMI-3 flow. But we stented this patient, the patient remained all right. So the debate is 15 days old, post-ACS plaque rupture patients, non-critical stenosis, whether to stent or not to stent. It's an evolving field. Now, this is third is an important, very interesting case. 55-year female, diabetic, non-smoker, normotensive. She was having 6 sinus under a pacemaker and episodic chest pain. She would get episodic chest pain with ST elevation, and that's why she was admitted. She had 2 episodes of syncope at her place. So we admitted. In the monitor, you could see polymorphic VT. You see, she was cardioverted, DC cardioverted, and taken. This was the ECG, some mild ST elevation in the inferior lead. And next day, she was taken up for angiogram. One can see there is some haziness here, and with NTG, the haziness goes. So this is a study by Akasaka. They have studied these vasospastic angina patients. Majority of these patients will have lumen irregularity or some kind of plaque erosion with endothelial, local endothelial dysfunction. So this is the data which Akasaka has published. So vasospastic angina, you can get this kind of pictures and they can produce this kind of catastrophic presentation. Our patient was having the same thing. You can see there is some white thrombus here with a white thrombus here, a luminal thrombus here with irregular lumen. So that's what was causing a vasospasm intermittently. So this patient was stented again to stabilize. And after 3 months, the pullback was good. The post-stent result, I'm not going because of to save my time. And 3 years post-PTCA follow-up of the patient is asymptomatic. We did a cardiac MRI to rule out any myocardial pathology at the end of the procedure, and it was absolutely normal. So this is another 60-year female, non-diabetic, hypertensive, non-smoker, chest pain 2 hours. This was the ST elevation in the casualty somewhere outside. When she reached the ST elevation has settled, the investigations were inconclusive. She was non-diabetic, and you can see there is a very borderline lesion in the LED. If you see this as an angiographic finding, you are never sure. And in acute MI, your FFR is not going to be very reliable. So I did an OCT. One can see, to our surprise, there was a CAD at 60 years female. There was spontaneous coronary artery dissection, and there was adequate lumen. There was no compromise of the flow. The lumen was adequate. In these patients, the algorithm says hemodynamically stable patients, conservative therapy, beta blocker, and one of the antiplatelet, you can continue. It was a non-communicating SCAD. If you have a hemodynamic compromise or a VT unstable patient, you have to stent those patients. And you have to keep these patients, most important, you have to keep these patients, don't discharge them immediately. Keep them in the hospital for 3-4 days to prevent ventricular tachycardia or some other catastrophic event. You can lose your patient. So we observed the patient 3 days in the hospital, 3 to 4 days. There was a T inversion here. At the time of discharge, the ECG was like that. At the follow-up, after 2 months, one can see there is a very smooth angio. This is the index. This is the follow-up angio. One can compare. This is a very good reconnaissance. We have done an OCT also. And you can see the OCT pictures, there is a very minimal residual hematoma, and the lumen has grown further big, very good lumen size, and the patient is doing very well. This is a comparative analysis at the index procedure. Look at the lumen here and look at the lumen here. It's totally healed except for the very proximal and distal edge of the hematoma. This is another CAD where you do
Dr. Mohanty, kindly conclude your slides. You're running very, very late.
Yeah, just a minute. I'll finish up. Okay. This is a 45-year male Again, a SCAD with LED occlusion. This is a courtesy from Dr. Sanjeev Roy, his case only. And look at this SCAD. It was obstructing the lumen, and look at the lumen, it's 1.4 millimeters. So this patient with unstable hemodynamic and ongoing chest pain has to be stented. So these are different kind of strategy in SCAD. And this is a last slide, SVG graft, very different in ACS. One can see these SVG grafts will have some cavitation like this in acute coronation. This is a sign of degeneration of SVG graft. OCT pictures are very typical. You don't have any intimal disruption, but inside the media or this layer, you can see such cavitations. This is a sign of SVG graft. And most importantly, you can choose your landing zone. If your stent is landing in this area, you have very high no reflow or failure of stents. So this OCT gives an insight into the vein graft landing zone, most importantly. And second thing, in vein graft, you can identify the venous walls also. If your stent is landing in that area, you can have a luminal compromise. Like in this case, we could not recognize the valve. We recognize, but we are sort of this valve, and we had to put a second stent because the venous valve was obstructing like this. So it has to be stented with second stent. So to conclude my talk, OCT can image precisely the lesion morphologies in SCS, not only the native artery, also after stent deployment. Different types of plaque disruption like plaque erosion, plaque rupture, and calcific nodule thrombus can be easily identified by OCT and managed appropriately. SCAD is not uncommon and can be precisely identified. An indication for stenting or not to stent, OCT is a very good method, but one has to be very careful to do the OCT. It may propagate the dissection or SCAD. OCT is extremely useful for non-atherosclerotic mechanism responsible, particularly for MINOCA and its management. SVG grafts can be imaged appropriately by OCT. Graft degeneration with other features like TICFA, plaque rupture, venous valve can be easily identified. Thank you very much for your kind attention.
Thank you, Dr. Arun.